We are about to participate in an interactive panel titled Brain Health Matters, Enacting Change, organized by Roche Canada. Please don't forget to tweet about your favorite events and panels at the conference using @Science Policy and hashtag CSPC 2022. Finally, please don't forget to fill out the evaluation survey for this session, which is part of the program app. Your feedback is important to us. And now I will turn it over to Robin Sakon, who is moderating this session. Welcome to the conference, and thank you.
I don't normally get to tilt the mic up, so I'm kind of excited because I feel tall. Normally it goes the other way. Well, greetings, everyone, and thank you so much for investing your time with us on Tuesday, November 16th. I'm so delighted to be here with you today and moderate this session on brain health enacting meaningful change. My name is Robin Sakon. I'm a member of the Roche Canada team from the Diagnostic Division, and this is my second year moderating a session at CSPC. I'm very delighted to be here in person this year. Before I take the opportunity to introduce our discussion today and the esteemed panel that we have brought together, I want to acknowledge as we gather here, I'm on the traditional land of the unceded Anishinaabe Algonquin territory. This acknowledgement calls on us to commit to continuing to learn how to be better stewards of the land we inhabit, as well as pay respects to the spirits. Our time together today, it will be focused on brain health, creating, enacting, and describing the importance of meaningful change. Brain health is a key example of where there needs to be an opportunity to increase awareness and the need for Canada to shift our system thinking to the better needs of Canadians now. For 125 years, Roche has been committed to improving lives. The long-term thinking of our founders shapes the way in which we make the difference in lives of millions of people around the world. Within the area of brain health, Alzheimer's disease, neurology, we believe in transforming care together. Alzheimer's disease, it's a chronic medical condition that leads to increasing severe memory impairment, behavior, along with social challenges. It's not part of the normal aging process. It is one of the biggest public health challenges of our time. There is a need to act and focus on it now. Over 55 million people are living with dementia, and with this prevalence projected to increase to nearly 140 million by 2050. The impact of Alzheimer's will intensify as populations age. The disease will eventually take away the person's ability to live independently, requiring family and friends to provide increasing levels of care, while medical costs also increase. We understand the heavy toll it takes on those affected, our grandparents, our parents, our friends, our communities. There's probably a close connection for many of us in this room. When I started working in dementia and Alzheimer's disease, it was around Alzheimer's Awareness Month. I went to pick up a purple ribbon to show my support and wear it on my lapel. What I quickly realized was that there was more than just a purple ribbon available. There was a blue, a yellow, an orange, and a white. Blue is a symbol of people currently experiencing Alzheimer's disease or another form of dementia. Purple, for those who have lost someone to dementia. Yellow, for those of someone caring for someone with dementia. And orange to anyone who believes in a future without dementia. And white to signify hope. That is 5 different types of ribbons. 5 different ways that people are impacted, and 5 different reasons to make this a priority. This is why we're here. This health priority is centered around prevention, early diagnosis, and improving services. I think it's safe to say that all of us in this room, and definitely on this panel, understand that there are challenges, and it goes beyond the capabilities of science. There are challenges that can only be overcome through partnerships, collaborations, adoption of innovation, and working with a strong AD community. Today, we are pleased to bring you those perspectives from a global context, national, and provincial, and have a focused discussion on what can shape the needs and what changes need to go into place for this to occur. On stage with me, I have Porrig Ward, head of Pharma International, Hoffman LaRoche, Laura Tamblin-Watts, CEO of CanAge, Jennifer Dotchkin, Senior Manager, Innovation Partnerships Strategy at the Hotchkiss Brain Institute and advisor to Campus Neuroscience Alberta, and Kathy Barrick, CEO to the Alzheimer's Society of Ontario. It may be 8:30 in the morning, but we're going to have a lively discussion. The COVID-19 pandemic was unprecedented, and the global response behind it was right there with it. It offers lessons for a growing health crisis in dementia. It shows stakeholders from different backgrounds, governments, healthcare professionals, private sector, scientific organizations, and the public, all coming together to mobilize and address a looming public health crisis. COVID-19, dementia, brain health share similarities in scale and in nature of challenges. Both diseases have a health impact that is concentrated among older adults, at-risk groups, and can cause broader societal and economic disruptions across families, communities, societies, workforces, and economies. Both share similar strategies for an effective response. To name a few: proactive public health and prevention efforts, accessible tools for early and accurate diagnosis, health system readiness, modernizing care from digital, access to data, and of course, accelerated research. To the audience, here's what you can expect of our time together this morning. Our esteemed panel will be presenting. Each will discuss a few projects, areas of focus, and the importance of contributing to the system shaping. At the end of the presentations, we'll look to have a dialogue. We'll kick us off with a couple of questions, and the panelists will have an opportunity to ask each other questions if they choose to do so. At the end, we've reserved 25 minutes to open up the floor to you, the audience. Feel free to ask your questions. Get involved. They're important to us. I will share with the audience that I will not be going through comprehensive bios today, focusing more on the content, but if you're interested in learning of the fabulous backgrounds that each of these individuals have, they're on the CSPC conference app and on the website. So let's get to our discussion. Our time together today, it's a bit of a journey. We're going to take you from global perspective to national to provincial. Our goal is, whatever your role is, shifting policy, health system planning, regulatory, that each of you come away with something, a new idea, a fresh perspective, a new strategy. And you can help to propel the healthcare system forward for those in dementia and those with neurological disorders. So Porrig, I'm going to turn the panel over to you, and you'll kick us off. So Porrig is the head of commercial operations at Roche Pharma International and a leading member of the pharmaceutical leadership team. He has an ongoing commitment to improving healthcare outcomes for patients.
Thank you, Robin. That's a way nicer bio than I would have given myself. So I'm responsible for leading one of the two divisions of Roche. We have a diagnostics division and we have a biopharma division, and I happen to lead the operations of the pharma division around the world outside the US. So it's easier for me to explain where my responsibilities are not than to explain where they are. So it's all the countries around the world except for the US. I hope you'll permit me maybe 90 seconds worth of promotion of Roche. I'm not sure how well everybody knows us as an organization. We're a Swiss-based company. We just celebrated our 125th anniversary. I have not been in the company that long, but we celebrated 125 years of existence. And it's actually 125 years of uninterrupted family ownership. So we're in the third generation now of the family. You can buy shares in Roche, but the family is there and is present and does retain a controlling influence over the organization. And that provides us with something which is very special to us and very precious to us, and that is the ability and the need to think about the long term. For sure, we're a commercial organization, so we need to make sure that we operate sustainably in the short term. But the decisions that we take and the way that we think about things is fundamentally driven by the long term. And that's an explicit instruction that we are given by our board of directors and by the family who run the company or who own the company. And the idea is that we should care about sustainability in all its aspects. So environmental sustainability for sure, but also the sustainability of healthcare systems around the world and the sustainability of our our ability to continue to invest in research and development. We pride ourselves on at least trying to always bring medicines and diagnostics which represent an advance on what's already there. The idea to bring better outcomes for more people around the world as fast as we possibly can. The company is the leading private investor in healthcare research and development. So there is no organization in the world, at least no private organization in the world, that invests more than we do each year. We're currently running at about $14 billion a year, US dollars a year, or Swiss francs a year, in research and development in healthcare. That means we spend an awful lot of time kind of looking over the horizon from a biological point of view, looking at trying to understand diseases, how they progress, and what might be done to change the natural course of a disease. Sometimes that is successful, and sometimes it isn't. And those of you who follow Roche might have seen that earlier this week, we had to announce the fact that 2 major trials of what we hoped would become a medicines for Alzheimer's disease were not successful. So we were not able, in this case, to help the people that we really, really, really hoped that we would. And that's disappointing. It's disappointing because actually what we do in order to help people. And so on behalf of those who we thought might benefit from this medicine, we're really, really disappointed. And then for the hard work that many hundreds of thousands of people within Roche put into it and the emotion that they invest into it, it's a blow. I mean, there's no doubt about it. It's a blow. But we pick ourselves up and we'll dust ourselves down. We will make sure that what we learned from the development of this molecule is made available to the community and to those researchers who will come after us. And that will start with a presentation of the data from the unsuccessful trials on the 30th of November at the Clinical Trials in Alzheimer's Disease Conference in San Francisco, and then, of course, publications and so on later on. The only silver lining in all of this is that even in failed attempts to advance care, there is learning to be had. And so we'll make sure that we learn from it, and we'll make sure that the learning is available to everybody else, and hopefully that will contribute then to better outcomes later. One of the things that we care about is the fact that whatever innovation we develop actually ends up in the hands of healthcare professionals so that they can use them to treat their patients. And I and my colleagues around the world, we work with healthcare system stakeholders to try and make sure that happens. I know quite a bit about how to run a biopharmaceutical company, but I would be the first to admit that I know nothing whatsoever about how to run a healthcare system. Right? I just don't know how to do that. And so I would never show up, and I think it would be the height of arrogance for me to show up and try to tell those who do how to do their job. I just don't know how to do their job. But what it can contribute, and what we at Roche are trying to contribute, is openness to conversation. We're looking for ways to be able to describe what it is that we're doing, and then to hear from others in the system what they are, to see if we can find common ground for making a difference for people. We've had quite a lot of experience of doing that in some disease areas. And over the past, 20 years, probably 15 years, we've done an awful lot of work in cancer care. There's still a lot to be done, but the kinds of conversations that we're having and the kinds of ways that we are able to come to common understandings of what needs to be done in order for patients to get diagnosed quickly, to get treated quickly, and to get followed up well are advancing. I'd have to say that in the area of brain health, that is much less true. It's much less true that we've been able to have those conversations. And I haven't got many examples to share around the world of healthcare systems where they are very well set up to do this. There are some, though. The UK stands out as being one of the countries where there's a lot of thought going into how to set the healthcare system up in order to make sure that people are followed well, that they are diagnosed quickly, then treated and followed up. And the ILAP program that they have put in place, which is a system where together with private industry, government, and others, they're looking at areas of They are of particular importance for public health, and trying to come together to find ways of making sure that research gets done, most often by the private sector, but then there is ongoing dialogue and a pathway to make sure that whatever comes out of it, when trials are successful, when new diagnostics are identified and so on, are quickly made available to patients in a way that is sustainable for both for the healthcare system and for those who have invested in the innovations. A long way to go, but there are positive steps there. And I hope I'll be spending the day with my Roche colleagues here in Ottawa today and engaging in discussions with public health system stakeholders. And I'll be bringing the same message, which is we'll explain what it is that we're trying to do. We're not going to tell anybody what we think they should do. We're prepared to listen to them and then hopefully come to a way of finding pathways where we can sustainably make sure that innovation is recognized and rewarded for the risk that's gone into developing it, and that healthcare systems can make those solutions available to patients when they are successful. So I might stop there and hand it over to the panel and then look forward to a discussion later.
Thanks very much.
Thank you, Padraig. I think openness to discussion, conversation, you're going to see that thread throughout probably all the things that we're going to talk about today, because it's really instrumental and it's foundational. So I'm going to call up Laura Tamblyn-Watts. She's the CEO of CanAge. And if you aren't familiar with CanAge, they actually just released a fabulous dementia report card that was cost-crunching. I'm sure she'll touch on it a bit more, so I won't go there. But she is the head of Canada's National Seniors Advocacy Organization. She is passionate in a variety of areas: long-term care, home care, financial security, elder abuse, healthcare, ageism, and inclusion of marginalized communities. Laura, over to you.
Thanks very much. Thanks very much, and thanks to our partner at Roche for putting on this wonderful conversation together. I have dementia. I have a serious health issue, but I cannot access the care, support services, or resources that I need. I'm not a has-been. I'm a person. Why am I so ignored? I feel lost, stigmatized, and forgotten. John, a person living with dementia in British Columbia. My partner has dementia, or at least some kind of cognitive decline anyway. We couldn't get a proper mental capacity assessment to figure out what's really going on. We're getting so worried. We can't get the help that we need. There isn't enough home care at all. Adult day programs or respite programs aren't even available anymore to us. There's not enough supports or help for caregivers. My parent is getting increasingly isolated. They're at home, alone, on the couch. But they just can't stay home any longer, but they can't get into long-term care. There seems to be no hope. Sarah, a family caregiver in Ontario. I work in dementia and social service sector. We've got all kinds of great programs we could implement if we only had the right supports. If I get the funding, it's for some kind of pilot project or some one-off. It's not just about volunteer time. We need to take this seriously. Everyone knows we need these programs, and we're going to need way more of them, not less. Why can't we succeed in getting the infrastructure that we need? A dementia support worker in Nova Scotia. Anyone here for whom that resonates, please raise your hand. I wear all of those colors of ribbons. I actually had no idea that there were those number of ribbons. I feel a little overwhelmed. I'm going to have to get a lot more ribbons, it feels like. What I wanted to talk to you a little bit today is some of the human side and also some of the system sides with dementia. And the numbers are real. We wanted to partner with Roche to look very strategically at how we're doing in this country and measure it. Who here has ever heard the term, if it's not measured, it doesn't count, right? Yes, exactly, right. So we ask the question, how are we doing? How are we doing in Canada? We've got this national dementia strategy. Kathy and I were on the stage. We shook hands. We have pictures with, ministers. It was all very nice, right? Everyone, there was cake, there was coffee. It was good. There was pictures taken. We were all in the newspaper. Yeah, and so what's happened since then? We asked. And we found that no one had a clue. And I like a good strategy as much, maybe even more than the next person, but it's got to be more than aspirational. So we looked around the world to say, who has measured a national dementia strategy? And we found out nobody has ever measured a national dementia strategy. And after we all just took a deep breath, we knocked on the doors to our friends at Roche and said, we need to find this out. So we worked with the World Health Organization and measured it out. Is Canada dementia ready? No. In case you're wondering, the answer is no. But it's not just like a little bit no, it's a giant no. So we didn't just look across the country federally, we looked in every single jurisdiction in the country, all the provinces, all the territories. The no got bigger, not smaller. And we kept thinking, this can't be right. This cannot be. And then we started breaking it down. We wanted to hear what our people were saying to us. And here's some of the things we found. In Ontario, this province, which is a big and rich province, 52% of general physicians, those people that are supposed to take care of our health. I know we often don't have GPs. That's another panel. Go across the way. We're probably talking about it there. 52% GPs did not feel comfortable recognizing, diagnosing, or treating someone with dementia. That's in Ontario. Go to the Yukon, 79% did not feel confident recognizing, diagnosing, or treating someone with dementia. The amount of time healthcare providers get over 4-year graduate degrees, 24 minutes on consent and capacity. Over 4 years. And I was saying earlier that as a lawyer, that's terrifying to me because actually consent is really important when it comes to healthcare. So we asked, well, what about geriatricians? We found that there are 10 times more pediatricians in the country than geriatricians. For kids, there's one pediatrician for every 2,822 people under 17, which is a smaller group because we have a lot more older adults. There's 1 in 21,000 seniors, and that number is getting better. So 327 geriatricians in the country. Do you know how many of those specialize in dementia? We don't, because it's not collected. Do you know how many people with dementia there are? We don't, because we don't keep track. Do you know how many billings there are for healthcare professionals on dementia? We don't, because there's no billing code for dementia. Let that sink in. There's no billing code for dementia in this country that's standardized. So what we indicated with our report card is this. There's nowhere to go but up. It's good. We can get better, right? The grades are very, very low. And we can start with some things. We can start with some education. We can start talking about some of the things that prevent some kinds of dementia. I know. Eat right and exercise. Yeah. But there's some other things we can do too. And Sudoku's fun. It's not helping you. But learning a new language can. Playing an instrument can. Stopping smoking can. And when we asked people what they were most afraid of in aging, it's actually not getting old. They were afraid of dementia. If we ask people, when you go and talk about your body and your health, what are you most afraid of talking about? And they talked about dementia. So stigma is something that we can really attach to. We've done it really well with mental health, right? We've been on the journey with mental health. And part of what we need to talk about now is brain health as part of that conversation. So Here's the wrap up. There's nowhere to go but up. We know how to measure it, and we have some really concrete ways of doing it. This is the public health crisis and the social health crisis of our generation. But with partners like folks at this table, we can do better. So there is some hope. And I'm hoping you get right back on that molecule, because one of the biggest reasons people don't try to get diagnosed, even if they could get the healthcare system to do it, is because they feel like there's no hope. And that's just not the case. So nowhere to go but up. And I'm hoping next year's report card's a little bit better.
Thank you, Laura, for that. So next, I'm going to turn this over to Jennifer. Jennifer is the Senior Manager of Innovation, Partnerships, and Strategy at the Hotchkiss Brain Institute. She shares her expertise in strategy and stakeholder engagement with many and collaborates to support research, innovation, and network development in the realms of neuroscience, mental health, and entrepreneurship. Jennifer, mic's yours.
Morning, everyone. Thank you for coming to the very first session. It's all very exciting, very friendly faces out there. You heard probably one of the longest titles. So I do have the Innovation, Partnerships, and Strategy. Not only are they three of my favorite things and things that I am very passionate about, but I think it's one of the core things as to why entities like Hotchkiss Brain Institute, and you'll hear about Campus Alberta Neuroscience, is so successful. So I'm going to be talking a little bit about both. So hands up, anybody's heard of Campus Alberta Neuroscience? Seeing a couple of hands, that's great. It's I believe the only provincial entity that brings together all of our neuroscience institutes within the province of Alberta. So it brings together the University of Lethbridge, which is the Canadian Centre for Behavioral Neuroscience. It brings together the Neuromental Health Institute at the University of Alberta, as well as the Hotchkiss Brain Institute, where I come in. Full disclosure, I used to be the executive director of Campus Alberta Neuroscience before moving into this role, so I know a lot about both entities. I'm not going to take the next hour, but I could, about all of the great things. I'm just going to give you a grazing of how the organization really aims to support innovation. So our catchphrase is where research meets innovation in neuroscience and mental health. The vision of the organization is to maximize the impact of neuroscience on those affected by brain and mental health conditions, and develop Alberta into an epicenter for brain health research, commercialization, and care. We talk a lot about building a neuro-innovation cluster. And also, we think we're funny, and we call them neuropreneurs. Oh, I'm hearing some chuckles, thank you. You've just made my morning. Because these neuropreneurs are really bringing that research and innovation and bringing it out to the world, and tackling all of those big challenges that we heard from your report card. And so a couple of the things that are really just the foundation of this work, we put them into 4 categories. First is developing the talent. So we work with a lot of trainees, students, as well as PIs to really learn the ins and outs of innovation, commercialization. Not everyone runs their own scientific lab. They work for Roche. They work for other industries. They create their own companies. They, launch new innovations. And so that skill set is very different than one taught within our universities, at least at this point in time. And so we spend a lot of time really equipping these people with the tools and the skills and the expertise to succeed. The next is really building those companies and jobs. So both Hotchkiss as well as Campus Alberta Neuroscience helps with actually creation of those. So sometimes that involves linkages with our friends in law to be able to access, patent information and how to build your company from the ground up, as well as really laying the foundation for this cluster. Is everybody familiar with the term cluster? I'm seeing head nodding. Okay, good. I will not get into that. So really building that cluster of neuro-innovation is something that we are very passionate within the government, and the government of Alberta has been very supportive of this. They're very, very keen on supporting life science innovation within the province. And the other thing is our collaborations and partnerships. The linkages with academic. When Campus Alberta Neuroscience was founded about 10 years ago, it was really about bringing all these universities together and bringing the expertise throughout. Each one of the universities has its own flavors. And so bringing them all together and being able to collaborate was something that we were very keen on doing. And about 4 or 5 years into the mandate, we realized, oh, wait, this has actually worked. We did a bibliographic assessment of the trajectory of collaborations, and everyone was definitely collaborating far more. But the areas that still needed a little bit of augmentation was very much in the realm of links to healthcare, to industry, other not-for-profit partnerships that really align all these health innovation and with real market needs. So with that became an industry and investment collaborations with venture capital groups, as well as other industry supporting entities throughout the province. So the network grew, and it grew, and it grew. Wait, that was starting to sound like a kid's book. So the collaboration really became a whole host of different entities. So the Alberta Neuro Network was founded, and that's a network of all of the not-for-profit groups within the neuro realm. The linkages with the strategic clinical networks at Alberta Health Services really grew. Ken was the founding member of the Neuro Strategic Clinical Network, collaborations with Alberta Innovates. And so it really became a focus on what can we do together. And a number of different items were really found. So the first is we're not just our logos and we're not just our organizations. We're a group of people. If we went around the room here, we would find that we had a massive group of individuals who were committed to their organization's goals and missions, and their passions would come through, and I wish that I could talk with all of you about them right now. But we would find that these partnerships were really the foundations on all of our different projects and all of our different sparks of innovation and excitement, and it's really all of you. And so I would invite you to come to, I guess my concluding component is that have coffee with people. Talk to them about what they're into, where you have overlap. I think that with all of the training and engagement and communication, and that it is the friendships, the collaborations, that was a really cool idea that I heard. Can we talk more about it? Those are the components that really will drive that innovation. I think I might actually conclude that there, because I could really keep going. Come chat with me about partnerships, collaborations, and we could talk about different programs and different ideas and how provinces could actually help each other and how we can all work together, because you are all sitting here, we all have, I'm guessing, probably the same vision for improved access, improved diagnostics, prevention, all of those things that make us all great humans. So thank you.
I think the children's book was by Robert Munch. I want to say that, if everyone remembers that.
Who has dementia.
And he actually, recently disclosed publicly that he has dementia. So, very appropriate for this discussion. So Kathy is the CEO of the Alzheimer's Society of Ontario. I would have to say, ever since I worked with Kathy, Her enthusiasm, her creativity, and her drive for impact comes through in every conversation. Kathy, I'll bring you up to the mic now.
That light is extraordinarily blinding. Good morning, and thank you, Robin, and thank you, Roche, for organizing this really exciting panel. As everyone has said, we're obviously extremely passionate about this topic and know that we need to do something, not tomorrow and not next week, but actually right this minute. I want to start by saying something that should be obvious, but is not obvious in our healthcare system, and that is dementia is not a normal part of aging. I'll repeat that. It is not a normal part of aging. So as, you know, in our family and friends, as people start to get older and perhaps they get forgetful, people say, oh, you're just getting older. Oh, I'm having a senior's moment. That is not normal aging. Although age is the primary risk factor. And so as our population ages, we've heard about this for a very long time, the boomers are getting older. We are going to be faced with a wave of seniors in our system. And of course, age is the primary risk factor. And so dementia is already a major issue, but it's on the cusp of being catastrophic within this country and the world, frankly. So I'll just give you some stats to kind of wrap your head around how big of a problem this is. So in 2020, there was just about 600,000 people in Canada with dementia. Now, we know that number is actually underreported. As you've heard Laura talk about, there's no billing code. So how do we actually know that? It's a good guess. It's reasonably close, but we also know there's lots of people that are not in that number. By 2030, and when I actually started working in this field a long time ago, 2030 seemed like a really long way away. It's in about 7 years. So get your head around that. 7 years is going to be 2030. I still think it's like 1982. In 2030, there'll be 1 million people in this country with dementia. And another 20 years following that, it's going to nearly double again to 1.7 million people. So imagine today at nearly 600,000 people in Canada that have dementia and the absolute incapacity of our system to deal with 600,000. Can you imagine in a mere 7 years trying to deal with 1 million people? And in another 20, 1.7 million, it's going to be, as I mentioned, catastrophic. Think about this as well. 29 people every hour in 2050 will be diagnosed with dementia. Every single hour. So as long as we've been in this room, another 29 people will have been diagnosed with dementia. So aside from the impact that it has on individuals, obviously it has a very significant impact on folks who are diagnosed with dementia themselves. It has a very big impact on the people around them, in particular their care partners. So as people continue to be diagnosed, the 2050 statistic is about 690,000 full-time equivalent positions. So 690,000 full-time jobs will be actually carried out by care partners looking after their loved one with dementia, which in the economic realm equates to about $1.4 billion worth of care that's going to be provided by care partners free of charge. So I've already said this, we're not ready. We're not ready today, and we're certainly not ready for tomorrow, and we're certainly not ready for 2030 and 2050. But what it will take is a systemic approach to solving the problem. And all of us here on the panel are part of that systemic approach. I imagine many of you in the audience are part of that as well. So it's going to need to include primary care, acute care, long-term care, community support services, and industry. And so one of the things we love working with Roche, full disclosure, is that, and we were very sad as well this week to learn that the molecule that you were hoping for did not meet your expectations. But the commitment of folks like you at Roche are that, this molecule wasn't it, but there's going to be more. And so the support of industry to help the systems get in place so that we will be ready is really critical. So one of the things that we did at the Alzheimer's Society of Ontario is we actually undertook a project to get people together, industry experts. In Ontario, incidentally, we also have an Ontario dementia strategy, which how do I say this nicely, I guess, went out the window with our current government. It was a Liberal initiative, so they no longer really call it the dementia strategy. And there were some investments related to the dementia strategy, and there actually continue to be some investments related to the dementia strategy, although they don't really call it that. But we at the Alzheimer's Society thought, well, not enough is happening. You know, Laura talked about how are we doing on the national dementia strategy? Failing grade. Failing grade in Ontario for the Ontario Dementia Strategy as well. So we actually came together with support of folks in industry as well and came up with a roadmap towards a renewed Ontario Dementia Strategy. And we took the approach that said, we want to provide the solutions to the government. Here it is. Here are the things that you need to do. Some of it requires money, but not actually all of it. Most of it does not require money. It actually requires systemic changes, things like something as what would seem to me to be simple, billing codes for doctors to be compensated properly, to be able to track people with dementia, to incentivize medical professionals to go into treating older adults, all those kinds of things. So we actually came up with 56 policy recommendations and 21 funding recommendations. And so this document, we believe, actually has the solutions for the Ontario healthcare system when it comes to treating dementia in a sustainable and coordinated way. The total investment for all of this implementation is $812 million, which you look at the healthcare budget is actually peanuts. They probably spend that on coffee and donuts when they take pictures of handshaking at the dementia strategy. Congratulations. So the $812 million investment is really not that significant, but it includes some really key recommendations that we know will help create the pathway for folks today, but into the future, who are dealing with dementia. So one of the things is actually creating a clear dementia pathway. So we talk a lot about cancer, and Cancer Care Ontario is actually, we hold them up as a really great example of an organization that's done something well. When people are diagnosed with cancer, they know exactly what is going to happen. They know the drug they're going to get, they know the treatment interventions, they know what support is available. That does not exist for dementia, so that's one of them. We also talked about the importance of a presumptive diagnosis, at least get people screened, at least get people to understand what they probably have. Of course, we want to make a lot of progress as well in a definitive diagnosis, but if we can't get there quite yet, at least a presumptive one. So instead of going to the doctor and saying, I think I'm having some memory problems, and the doctor's saying, oh, you're just getting old, we want doctors to say, tell me more about that and let's get some more information. We need coordinated care. If you know anybody in the system right now who is needing community support services, health care, acute care, it's a bit of a dog's breakfast. There is no coordination. You have to repeat your story multiple times. The people who come into your home who provide care to you, change all the time. It's just not a good system for coordination to make sure that people aren't falling through the cracks. We need professional dementia training. Laura talked about 24 minutes of education on capacity. Frightening. I think we did a study a while ago, or looked anyway. I think 6 hours of medical school is actually focused on brain, things that could happen in your brain. The brain is probably one of the most important organs in your body. It makes your body do everything, and without your brain working properly, the rest of your body is going to have a bit of a problem. 6 hours in medical school on focusing on brain. And some other real tangible recommendations in the report as well, including tax breaks for folks who are spending their own money on caring for people with dementia, as well as direct access to funding. And so we've actually had some interesting demonstration projects of, instead of the system deciding how we want to support people with dementia, we actually give them the cash and say, how do you want to be supported? And so, it's not a cookie cutter approach. So the Alzheimer's Society, we're in communities across the country, and I'm obviously here from Ontario. We have some really great programs and supports for people living with dementia. We know they're not enough, but there are some really interesting pilot programs, as we call them. And was it you, Laura, who said, a pilot project is really cool. It usually demonstrates that it really works, but when the pilot's over, well, then what? Where do you get the money to carry it on? But there are some really good things happening. So there's a pilot happening right now in the emergency department. One of the places where people with dementia show up the most is in the emergency department. Two things often happen is they get sent home without support, if they can actually discharge them from the emergency department, or they end up in ALC beds. And 50% of the ALC beds in Ontario are filled with people living with dementia. They do not need to be in hospital. They don't have an acute care need, but they cannot be safely cared for at home. So a pilot in Hamilton has Alzheimer's Society staff in the emergency department to try to divert people from admission and get them hooked up with supports at home. We do things like in-home recreation and in-home respite because we know that without supporting care partners to have respite, instead of the healthcare system having one patient, which is the person with dementia, they're going to have two. The care partner becomes a patient as well. And we actually just entered a really exciting partnership to look at the actual impact of day programs. So day programs in communities, we know anecdotally they really make a difference, but there actually is not a lot of data to support that, which is actually another issue within this field, is that not a lot of people have spent a lot of time demonstrating impact for people living with dementia of a variety of ways. So at the height of the dementia wave, it'll take Ontarians 7 years to get a diagnosis. So aside from that being absolutely unconscionable, can you imagine being told you can't get a cancer diagnosis for 7 years? We would be picketing about that. It should be the same for people with dementia. So again, aside from it being unconscionable, it's actually going to create a real problem. We are hopeful. We know there is going to be a disease-modifying therapy in the near future. And it will be too late. If you cannot get a diagnosis for 7 years, that disease-modifying therapy is not going to help you. It will be too late for you. We know that the long-term care capacity already is stretched to the limits. It will not have availability. You will not be able to get into long-term care. And even perhaps just as bad or maybe worse is that the community care support is inadequate. And at this current trajectory, it's not going to keep pace with the demand. And finally, care partners will be burnt out. We're going to have a system filled with care partners who really just cannot cope any longer. And again, as I said earlier, we're going to have 2 patients instead of 1. So without immediate action in Ontario and across Canada, we are headed for an absolute catastrophe. And so us on this panel, and hopefully many of you in the room, it's going to be through a concerted effort of advocacy, policy changes, increased public awareness, and treatment advances. That's going to be the solution, but we have to start today. So thank you very much, and I'll turn it back over to you, Robin.
Awesome. Okay. I like not being tied to the podium, I'll tell you that. So I'm going to ask our panelists to sit there. But thank you all for, I think their passion comes out in everything that you've heard in the last little bit. And there's common threads that weave through them all. So I'm going to start off the question, and then I'll turn it over and see if the audience has any questions. So I think everyone in this room has heard. Roche Canada has done a lot of engagements. We've gone out, we've talked to our external environment because we see that as being super important to how we're going to affect change. And these are change leaders, and we're so honored to be working with you. So thank you for, entrusting us with that responsibility. So through those outcomes and through the engagements, we've heard 3 things that have consistently resonated: improved diagnosis, sustainable access, and system resilience. So my ask of the panel, are these the right 3 outcomes to implement change? Is there anything you would take away or anything you would add? So again, the outcomes are improved diagnosis, sustainable access, and system resilience. Who wants to start?
Oh, pick me.
Okay, Laura, you're first. Go ahead.
So yes, but also, right? But also, I know that there's a little bit of setback, but that's how science works, right? And so I don't think of it as a setback. I just think of it as key learnings and then move forward. I need you guys to get a disease-modifying treatment. I really, really do. It's not just me. We all need that, because I think one of the pieces that I was talking about was hope. And so I would add hope to that. There are things we can do, but they're not well coalesced. And hope on the one hand with the disease modification treatment. And on the other, it's that stigma piece. It really is. I can't emphasize to you enough how stigmatizing dementia is. So if you don't want to know, you're not going to go find out. And then it's going to be too late for any of the disease modifications or even, the modifications of social modifications. So hope on the one hand and reduction of stigma on the other.
If I could add on to that, it's funny. It was striking to me listening to the three of you that in this particular case, I think we all know what needs to be done.
Yeah,
it's not like there's any mystery about what needs to be done. And for sure, it would definitely be better if there were disease-modifying therapies out there. And one of our competitors, I think, will present some data next week or the week after, which does look kind of promising. And I'm really happy for that. It's a weird industry, actually, where you can be very happy for your competitors. But because of the fact that we actually work with a purpose, we work with intent, we want people to benefit from things, we want people to get better outcomes. So if we can't do it, then at least somebody else can, and we're happy for them. We're going to continue to be very determined in all areas of neuroscience, including in dementia, and we're going to keep at it for as long as we can. What we need in order to sustain that, for us anyway, is a belief that if we are successul, that then the system will be set up in a way that people can benefit from it. It means that the way that we evaluate a medicine when it comes, that there's a pathway to getting it made available at a sustainable price for us and a sustainable price for the system. And we've always committed, and we will commit to being responsible about that. So that's one part of it. But then it's also about, can we actually help physicians to be comfortable about identifying patients early on? Can we make guitar lessons and language classes available for people so that they can sustain themselves as they go? So that then, if and when we have a disease-modifying therapy, it can be even more impactful than it otherwise would.
Yes.
So I think we kind of all see what needs to be done. And as always, it's the behavioral and the organizational part that's the hardest, isn't it? It's kind of getting together and trying to figure out a way of organizing all of that in a way that it can come together.
As an aside, you don't have to be good at the music or good at the language. It's the learning of it that matters, because I might fail on either of those. So
I think one thing I would add to your list, which I think is excellent, is prevention. We look at other, major diseases, heart and stroke comes to mind, cancer. They've done actually a very good job, I would say, we all could probably rhyme off. Now, whether we do it or not is another question, but we could probably rhyme off the things that we need to do to avoid heart attack and stroke. We know we need to eat healthy, not smoke, get regular exercise, etc. So we need to do a better job in the dementia space of helping. Frankly, they're the same things. So we can just piggyback off of the work done by many other organizations. But, even, the numbers I gave, even if we do the best job at getting the system ready, 1.7 million, that is going to be overwhelming, even if we do an excellent job. So we actually have to intervene now as well in helping people prevent it to the best of our ability.
I think that, so my background is policy, and so the first thing that comes to mind is that we need to have advocacy. But what I know from advocacy is this, and going back to my roots at the Hotchkiss Brain Institute, is that we need a solid foundation of research and knowledge and what is actually coming down the pipeline. I'd like to give a shout out to Dr. Jenny Young. She's right there in white there. She is the CEO of the Brain Research Strategy, or the Canadian Brain Research Strategy. And she is really driving this research in the area and really trying to support basic research as well as all types. You should go and chat with her later on too. But brain research, see, this is what I do. I just try and get people to connect.
But this is what's important, right? This is how we actually make change.
Absolutely. And so I don't know if this is happening throughout Canada, but certainly in Alberta, there has been significant reduction in research funding in the neurosciences within universities. And so being able to continue that advocacy of that basic science is really important. Sometimes it's so complicated, I do not understand it, but it is very important that there are people out there who do understand it.
Excellent. Thank you, guys. I like when I can add to my list and make it more robust, so I appreciate that. And I think it will lend to a more fulsome discussion as we kind of try to bring this back. Well, if there are any questions from the audience, I'm happy to put them in front of the panel. I'll give you guys a chance. If not, I will offer one more. Oh, two. Okay. I'm going to come here because we're closer.
So you mentioned that we need that solid research strategy, and we need people to utilize that research. So it sounds like we have answers. We know what we need to do, but it's really hard to get that implemented. So how do you coordinate, amongst multi-levels of government to get that strategy in place? And how do you get those researchers to be at that table bringing forward that advocacy? Because it just seems like there is a huge disconnect between what actually gets generated and then the people who understand it. And sorry, I realize this is a really long question, but like researchers who are doing the work, I actually do work in Alzheimer's research as well. But they're overwhelmed with the work they're doing. They're just focusing really hard to get that research generated, find that solution, find that biomolecule to treat patients. How do you motivate them to be at that table and now devote a whole other portion of their time towards enacting that change?
I think behavioral economics comes in here, frankly, and we have good evidence that if there are areas of promotion, people will focus on those areas. And when we're thinking about capacity building across the spectrum, I think of it as a life course approach. So we need to get people who are interested in older adults, step one. We need to get people interested in brain health, step two, and then dementia, kind of step three. And if you're talking about that pure flow through of research, how do you prioritize people going into certain areas? I mean, we know that if there's grants and research dollars and prestige and awards and so on, researchers will prioritize the areas for which there are supports and funding. That's not brain surgery, ha, ha, ha. No, I mean, we know this, right? We've done this in other areas. Yeah, that little neuro joke there. But I think it's also important on the back end of that question that you ask is, how do you sustain that? As to me, the bigger question, once you get people into that space, how do you sustain that space? And that's why we're really proud partners with Roche, I have to say. And, not every advocacy organization will sit and say, we're really, really excited about our relationship with a private company, but we are. Because the mentorship opportunities, the taking it seriously in the hearts and minds, we think that sector approach is really helpful. And so having organizations with open arms that will provide training opportunities, mentoring opportunities, and frankly, hope and room to grow, I think those researchers need to land somewhere. And so I'm really proud of the work and the attitude that this company has done. And then that advocacy piece, right? We need to make sure that they're well trained to be able to translate their research information and mobilize that knowledge in a way. And so, I give a talk called How to Become a Public Policy Rock Star for Researchers, because in the end, yes, a publication in a high impact journal is really important. But if you're boring and you can't explain what you do, mostly nobody cares, right? And so you can just hope that somehow your research impacts will show up, but we know that that's not the case. So the last part, training on public policy and knowledge mobilization for researchers helps their careers and then helps us understand what they're doing.
I think I would add to that. You should do a TED Talk on how to be not boring, or no one will care. That was actually brilliant. But I think, further to what Laura's saying too is partnerships. So if researchers, we need you to be doing your research. And so to your point, we don't want you taking away from your research time to go and talk to politicians who may or may not care. But partners like me will gladly take whatever it is you're learning and represent in the best way that we can as part of our evidence. Because one of the problems with dementia, as you've heard from the panel, is not a lot of people have paid attention to it. People don't pay attention to aging in general, but dementia specifically. So we need data to demonstrate to the government. And again, the economic data, that's what the government cares about, is how, interventions, new treatment modalities, et cetera, are going to save the government money. That's what they're really interested in. So finding partnerships that can carry your message would be critical, I think. or take Laura's course on how not to be boring and do it yourself, whichever.
Okay, we'll have one more question.
Hi. I guess you partially answered the question just in terms of researchers and clinicians focusing in on training, like we need better training, et cetera. I was really struck by 7 years to diagnosis. And so that seems like one of the solutions. That's what I was going to ask about. But is there, in particular with clinicians, a barrier to them actually diagnosing? Like I've had parents with dementia, I've seen that, I've been to the doctor's appointments and so forth. And the nuanced language, yes, I know the brain tests, the memory tests, all that stuff, but it seems like there's a barrier to actually calling it what it is and recognizing it early on. So both from a diagnostics perspective, in terms of whatever tools are being used, and from a clinician perspective, it seems like there's a lack of will to do this for a number of different reasons, but there also appears to be an acceleration of what will be required to cope with this wave that's coming. So it's more a comment, but it seems like that's a very important solution, particularly as diagnostics come in. And then what can be done to slow or blunt that?
Well, I would give a big thumbs up to that, and my diagnostics colleagues are sitting down here and are making great progress towards that. In fact, as part of that outcome, I'm mildly terrified to continue talking here in case I end up being boring. But I would say
that could never happen.
I would say that there is something else that we can learn from other diseases where we have made good progress. And I started my career I had worked in another company before I joined Roche 18 years ago, and I was working in Portugal. And at that time, which is not that long ago, even then, in some parts of the country, it's an advanced Western European country, even in some parts of Portugal at that point in time, people were still having their relatives' death certificates changed so that it didn't say that they had died of cancer because of the stigma that was attached to it. Happily, that's not the case now. But the way that it changed was because all of the things that we've been talking about here in the context of brain health have happened since, to the point where people recognize it more quickly. The stigma attached to it has gone away. And so it's not a very practical thing, perhaps, but I think I wouldn't underestimate the importance of just talking about this, talking about the fact that, as you said, it's not an inevitable consequence of getting older. It's a healthcare problem which needs to be addressed, which needs to be talked about, and which needs to be managed.
So the project that Campus Alberta Neuroscience is just kicking off in Alberta is actually one of diagnosis. And it is a digital health platform. And we approached it twofold, and actually addresses your question as well. One of the things that I find probably the most useful when planning your strategy is all about what's in it for me. And not like me personally, but what's in it for the person that you're working with. So what's in it for the patient, what's in it for the providers. And so we looked at some of the drivers of, I don't know if you know this, but family physicians are really busy, like really busy. Like you add one more thing to their plate and they're like, no, so they would like less things on their plate and would like tools to be able to support them. So working with Roche, we're working on a digital platform that enables the patient to do some testing. It offers some other services that will be provided to them. So it's like a one-stop shop. It actually decreases perhaps the family physician workload, gives them a tool. So we'll be offering, so the incentive is that they'll be getting an iPad for being able to track and have easy access to the digital platform, and actually being able to help with that diagnosis and with the management. And so hopefully we can decrease that 7 years down to much, much sooner.
I think just building on those two great points, there's really no other disease that takes away your right to have sex or get married or vote or run your money or drive or lose your ability to make decisions about where you live, what you eat, and how you dress. And so one of the drivers we know that is a push back against is our legal systems, which say that if you have a mental capacity challenge at a certain point and so on, we're getting a bit better about that, you can't do all of the things that make you a legal person. So if I have a cancer diagnosis, okay, I have a bit of a sense now about my journey, but doesn't mean that I can't have intimate relations with my husband or vote in the next election. If I have a heart and stroke diagnosis, okay, I understand the journey, but it doesn't immediately mean that I'm probably going to lose my rights to spend money and choose where I live. And until we address that reality, we have a presumption of capacity. So until you get a diagnosis and then some testing, you're presumed to be mentally capable of doing all those things. So I hear people say, why would I ever get a diagnosis if there's no hope on one side, which is, by the way, not true, okay? But if that's the public perception, and the downside of getting a diagnosis is I lose my rights, why would I do it? And that's a good question. Now, our legal systems are changing. We've got UN conventions. Love to talk to you about that. We're moving into supported decision-making, but mostly they're right. And until we stop having those pulling away of rights, I think a diagnosis without a lot of clear hope has real personhood issues that we haven't really grappled with in the way that we need to.
One thing I would add as well, we're talking a lot about early diagnosis, which is critical, but there's a distinction between early diagnosis and early detection, and we actually need to be much better, and there are some innovations starting to come in terms of early detection, but there are things that can be done. We're actually participating in a study right now with retinal scans. So when you go to your optometrist and they can look in your eyeball, we know that amyloid shows up there, well, maybe not first, but you can see it there many years before any symptoms actually happen. So when we're talking about hope and disease-modifying therapies, can you imagine if you were offered a disease-modifying therapy before your rights were taken away as a person, before you even had any symptoms at all? So early diagnosis, yes, when people are starting to show signs, we need to intervene and support them through that diagnostic process. But even better is early detection. How do we start to tell that people have disease happening in their brain at a point where their brain is not yet lost in many capacities, that we can support them, so that perhaps the disease will never progress to a point that it's symptomatic at all?
Well, I think this has been a great discussion. I hope you guys have enjoyed it as much as I have. So we're going to wrap up there, and we're just going to encourage everyone in the room, be bold, look for those key opportunities to enact change, and hopefully we've given you some ideas today. So thank you for joining us.
Thank you.